Okay, so we're going to go ahead and get started. Hello and welcome to iTenv Healthcare Solutions webinar. Today we're going to be presenting MACRA, breaking down the proposed rule. My name is Chelsea Grover and I'm the Marketing Communications Coordinator for iTenv. I'd like to take a moment to explain the process for today's presentation. First, I'd like to mention that this webinar will be recorded. Next, for those of you who aren't familiar with iTenv, I wanted to share a bit of who we are with you. We've been in business as iTenv since 2003, but have been next-gen users since 1997 EPM version 2.3. We specialize specifically in next-gen healthcare. Our development team knows how to get data into, out of, and around next-gen to customize it and tailor it to meet our clients' unique needs. Our purpose in life is to create delighted clients by helping them get the absolute most out of their next-gen software investment. It is our passion to provide solutions for our next-gen provider healthcare partners, which in turn help them to improve patient care, enhance the patient experience, and maintain a financially healthy practice. We really do everything next-gen, from implementation to consulting, hosting, customization, support, and we have two next-gen add-on productivity solutions, ChartGuard and Refund Manager. So we're still putting together our upcoming webinar schedule, so stay tuned for updates on that. Follow us on Facebook, LinkedIn, and Twitter to be the first to know. We also provide weekly tech tips there and are always happy to answer questions. Okay, so going back to MACRA. At the end of the presentation, we're going to open the floor up to questions from you. We will answer all the questions in the end, but you may type them in the questions area of the webinar control panel whenever they occur to you. For your reference, we're also going to be emailing out links to the recording and PDF of the presentation later this week, as we do with every webinar. Also, I wanted to point out that all the images and graphics used in today's webinar are from CMS unless otherwise noted. Finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please use the chat box to let us know so we can resolve them. So without further delay, I'd like to introduce our presenters for today, Lindsay Lanning, Cindy Kincaid, and Kathy Thompson. Lindsay Lanning originally joined us from the Ohio State University intern program, where she was getting her degree in Health Information Management Systems. After graduation, Lindsay joined our team as a Healthcare Informatics Coordinator, where she spends her time immersing herself in the ever-changing healthcare IT environment and educating the rest of the company on new issues and trends in the industry. Cindy Kincaid is Vice President of Consulting Services at iTenv and a Certified Practice Management Executive. With over 25 years in the IT healthcare industry and over 9 with iTenv, her experience runs wide and deep. This makes it possible for her to provide to help healthcare organizations experience great success no matter what the challenge is. Kathy Thompson is also going to be on our webinar today. Kathy has been with iTenv for 10 years. Prior to joining iTenv, she was a medical assistant at a neurosurgical practice. This is where she got her first taste of NextGen and has been hooked on it ever since. Currently, she is a managing consultant at iTenv, where she specializes in NextGen EHR and incentive programs, which makes her an excellent resource with this presentation. Okay, Lindsay, I'm going to go ahead and pass the webinar off to you. Feel free to get started when you're ready.
Great, thank you, Chelsea. So hi, everyone, and thank you for joining us today for our webinar, MACRA, Breaking Down the Proposed Rule. So here we find ourselves again, less than a year later after the modified Stage 2 Meaningful Use Rule was released, with another industry-altering proposed rule. With the ever-evolving healthcare landscape, we wanted to take the time and help our provider partners better understand MACRA and the newly proposed Quality Payment Program. We will focus on the Merit-Based Incentive Payment System, or MIPS, and answer the questions: who will participate, what is the performance period, and what possible payment adjustments could there be. Our objective is not to bore you to death today with the amount of information that's in this presentation. It's dry and it's very technical material, but we think it's important to leave you all with an understanding of the changes put forth by MACRA and what to expect and how to prepare for these changes in 2017. So stick with us throughout this, and please come back to the slide deck as a resource for your own practice. So in today's webinar, we will look at an overview of MACRA and the Quality Payment Program, focusing on one of the 2 tracks offered through this new program, MIPS, where we will break that down and analyze each of the 4 performance categories found within MIPS, which are quality, resource use, clinical practice improvement activities, and advancing care information. We will then look at how MIPS is scored and get an idea of what type of payment adjustments providers can expect to see starting in 2019. We will briefly look at APMs and their role in the proposed rule, and we will end on ways you can prepare for MIPS in 2017 and ensure your success with this new program. Really, our primary focus today will be MIPS. We will go over APMs briefly, but CMS predicts the vast majority of clinicians will be subject to MIPS in 2017. So that's what we really want to make sure you all are prepared for. Now, before we get started with MACRA and MIPS, we did want to point out there have been a few announcements in regards to the immediate future of meaningful use in MACRA. The Centers for Medicare and Medicaid Services proposed earlier this month that providers will only need to attest to meaningful use for a 90-day reporting period in 2016. This would be down from a full calendar year for returning participants. The agency has also proposed to allow a hardship exemption for the meaningful use portion of MIPS, or Advancing Care Information, if this is your first year of MIPS and you've never done meaningful use before. They also propose to change how measures are calculated. And lastly, they've specified that all participants must do modified stage 2 in 2017. Stage 3 is no longer an option because the CMS attestation portal won't be ready. CMS included this provision in the Hospital Outpatient Prospective Payment System Proposed Rule, or OPPS. The OPPS proposed rule is open to public comment until early September, and it will likely not be finalized until after the start of the last available 90-day reporting period, which is October 1st. And if anyone else in the line is having deja vu like we are, you're not alone. We've been here just last October in the same situation. So since we will not know until late in the year if a 90-day reporting period is final, clients should have a plan in place for a full year of meaningful use reporting. And then also announced this month was a possible MACRA delay. CMS Acting Administrator Andy Slavitt told the Senate Finance Committee the agency would consider delaying the implementation of MACRA, set to launch on January 1st, 2017, due to the concern that physicians and group practices may not have sufficient time to prepare for the implementation of the new program. So that means CMS now has the lovely task of creating and finalizing the much anticipated final rule for MACRA and providing a final decision on meaningful use changes all this fall. Now let's get back to MACRA and start with an overview of the legislation. So on April 27th, 2016, the Department of Health and Human Services issued a notice of proposed rulemaking to implement key provisions of the Medicare Access and CHIP Reauthorization Act of 2015, or MACRA, a bipartisan legislation that replaced the flawed sustainable growth rate formula with a new approach to paying clinicians for the value and quality of care they provide. This legislation was supported by 93% of lawmakers, which is unheard of, and which also means it will likely not be repealed. So if we look at payment prior to MACRA, it was the fee-for-service payment system, where clinicians are paid based on volume of services, not value. Each year, Congress passed temporary doc fixes to avert cuts in reimbursement. If MACRA did not repeal the sustainable growth rate formula in 2015, there would have been a 21% cut in Medicare payments to clinicians. So really, what MACRA did first was it replaced the SGR with a more predictable payment method that incentivizes value. And it also created the Quality Payment Program. The Quality Payment Program is a part of a broader push towards value and quality. In January 2015, the Department of Health and Human Services announced new goals for value-based payments and APMs in Medicare. MACRA is the first step in achieving these goals, for which we are ahead of schedule and have already surpassed Goal 1 of 30% this year. So this graphic supplied by CMS lays out the goals HHS has set for us as a nation on our way to value-based care. So like I said, Goal 1 was to have 30% of Medicare payments tied to quality or value through alternative payment models, or APMs, by the end of 2016, which we accomplished early on. And we are well on our way for Goal 2, which is to reach 50% by the end of 2018. Really, what MACRA is the final push towards value-based care. And it does this through 3 important changes to how Medicare pays those who supply care to Medicare beneficiaries. These changes create a quality payment program. And number 1, it makes a new unified framework for rewarding healthcare providers for giving better care, not just more care. This unified framework has 2 paths: the Merit-Based Incentive Payment System, or MIPS, and Advanced Alternative Payment Models, or APMs. Number 2, it ends the SGR formula for determining Medicare payments for healthcare providers. And number 3, it combines our existing quality reporting programs of meaningful use, Physician Quality Reporting System, or PQRS, and value-based modifier into one new system. These proposed changes, which CMS has named the Quality Payment Program, replaces a patchwork system of Medicare reporting programs with a flexible system that allows you to choose from two paths that link quality to payments. If we look at these two paths in terms of participation, CMS predicts the majority of practitioners will be subject to MIPS in 2017 versus APMs. This graphic displays the types of providers who will be subject to MIPS. So we have those who are not in an APM, those in a non-advanced APM, and those that are in an advanced APM but did not qualify. And what I mean by that is some clinicians may be in an advanced APM but not have enough payments or patients through the advanced APM to be a qualifying participant. So let's take a look at the Merit-Based Incentive Payment System, or MIPS, since most Medicare clinicians will initially participate in the Quality Payment Program through MIPS. The first performance period for MIPS would be from January 1st, 2017 through December 31st, 2017. MIPS combines the requirements of PQRS, VM, and meaningful use into a single improved reporting program. Therefore, the last performance period for these separate reporting programs would be January 1st, 2016 through December 31st, 2016. The first payment year for MIPS will be 2019, based on the first performance period of 2017. MIPS aims to provide flexibility in choosing activities and measures that are most relevant to a practice and their scope of work. And the major components of MIPS include eligibility, performance categories, data submission, and payment adjustments, which we'll go over next. So first up is eligibility. We have had a minor vocabulary change. It's no longer an eligible professional. EPs will now be called MIPS eligible clinicians, or ECs. And these ECs are the Medicare Part B eligible clinicians affected by MIPS. And in the first 2 years, these include doctors of medicine, doctors of osteopathy, doctors of dental surgery and dental medicine, doctors of podiatry, doctors of optometry, chiropractors, PAs, NPs, CNSs, and CRNAs. Now, in year 3 and beyond, the Secretary may broaden eligible clinicians group to include others, such as physical or occupational therapists, speech-language pathologists, audiologists, nurse midwives, etc. So who's not eligible? There are 3 groups of clinicians who will not be subject to MIPS, and they are those in their first year of Medicare Part B participation, those who are below the low patient volume threshold, which means Medicare billing charges are less than or equal to $10,000, and they provided care for 100 or fewer Medicare patients in 1 year. And finally, participants in advanced APMs. We do want to note MIPS does not apply to hospitals or facilities, nor does it apply to Medicaid. That means if you are a clinician who bills under both Medicare Part B and Medicaid, and you are above the low patient volume threshold, then you will have to dual report or you will see penalties from Medicare. So MIPS categories. MIPS allows Medicare clinicians to be paid for providing high quality, efficient care through success in 4 performance categories. The first being cost, which is 10% of the total score in year 1, and it replaces the cost component of the value modifier program. It's also called resource use. The score will be based on Medicare claims, meaning no reporting requirements for clinicians. And this category would use more than 40 episode-specific measures to account for differences among specialties. Next is quality, and it counts for 50% of the total score in year 1. It replaces the physician quality reporting system and the quality component of the value modifier program. And clinicians would choose to report 6 measures versus the 9 measures currently required under PQRS. This category gives clinicians reporting options to choose from to accommodate differences in specialty and practices. Next, we have clinical practice improvement activities, and it counts for 15% of your total score in year 1, and it is a brand new category and program. Clinicians will be rewarded for clinical practice improvement activities, such as activities focused on care coordination, beneficiary engagement, and patient safety. Clinicians may select activities that match their practice's goals from a list of more than 90 options. In addition, clinicians would receive credit in this category for participating in alternative payment models and in patient-centered medical homes. And then finally, we have advancing care information. And this counts for 25% of your total score in year 1. And it replaces the Medicare EHR incentive program, also known as meaningful use. Clinicians would choose to report customizable measures that reflect how they use electronic health record technology in their day-to-day practice, with a particular emphasis on interoperability and information exchange. Unlike the existing meaningful use program, this category would not require an all-or-nothing EHR measurement or quarterly reporting. So we're just going to work our way through each category and provide you with a high-level overview of the reporting requirements, key changes from the previous program it replaces, and important takeaways for each of the 4 MIPS categories. So if we start with quality, CMS created these simple bulleted lists for each category I really like and I wanted to include. I think it does a great job of breaking down the category and showing providers what they really need to know. So for the quality category within MIPS, clinicians choose 6 measures to report to CMS that best reflects their practice. One needs to be a cross-cutting measure and another an outcome measure, or a high priority measure if an outcome measure is unavailable. Clinicians can choose to report individual measures or a specialty measure set, and all of these quality measures are available in the proposed rule. So what are the biggest changes providers can expect to see transitioning from the PQRS program currently in place to the MIPS quality category? Well, we identified 3 main areas: requirements, scoring, and CAPS reporting. With requirements, we know PQRS required 9 measures across 3 domains. However, MIPS quality requires only 6 measures with no domain specification. Scoring is a little different as well, just because the credit received for the category, as well as the other 3 categories, will be put towards an overall score versus a pass-fail methodology we're used to. And finally, CAPS is no longer required for groups of 100 or more ECs. However, you may want to keep in mind that bonus points can be earned for reporting CAPS. So if we look at how ECs report data, we can see they select 6 measures that includes 1 cross-cutting measure. And some examples of these are care plan, BMI screening and follow-up, or tobacco use. And 1 outcome measure, or if an outcome measure is not available, you can do 1 high priority measure. Some examples of these that are currently supported by NextGen include controlling high blood pressure, depression remission at 12 months, or improvement in blood pressure. In total, there are about 250 measures, and 189 of them are ambulatory measures. NextGen supports 55 with EHR reporting, 95 with registry reporting, 11 ambulatory cross-cutting measures, and 10 outcomes measures. NextGen also currently supports some specialty measure sets as well. So keep an eye out for more information from them on additional measures added to the HUM for MIPS. So our key quality takeaways are that, number 1, quality performance category weighting will count as 50% of MIPS in 2017. But it will slowly decrease to 45% in 2018 and 30% in 2019. MIPS quality measures must be captured from January 1st, 2017 all the way through December 31st, 2017, and they must be submitted to CMS by March 30th of 2018. There are different reporting submission standards and measure sets for individual eligible clinicians, small groups, specialties, and large groups, which we'll touch on later. And an EC score will be based on performance. And the nice thing about this category is the EC is not required to report data. It can be collected automatically. Moving on to the category cost or resource use, which will compare resources used to treat similar care episodes and clinical condition groups across practices. ECs will be assessed under all available resource use measures as applicable to the clinician. So CMS calculates based on claims, so there are no reporting requirements for clinicians. And some key changes from the current program, which is value modifier, are that it's adding 40+ episode-specific measures to address specialty concerns. And its weight in year 1 will be 10%. So another great thing about this category is that CMS will calculate resource use performance using administrative claims data for Medicare patients only, which means no data submission or additional information required. Now we know the value-based modifier program had 6 measures, whereas the new MIPS category only has 2. Total per capita costs for attributed beneficiaries based on a 2-step attribution methodology, so similar to the existing process, and the Medicare spending per beneficiary to measure cost of care surrounding hospitalizations. There are additional episode-based measures which will be examined. CMS proposes 41 clinical condition and treatment episode-based measures. The other measures removed were the current total per capita cost measures for 4 condition-specific groups, which were COPD, CHF, CAD, and DM. If we look at a few more differences found between the value modifier and the proposed MIPS cost category, we can see how the program is shifting and evolving to accommodate value-based care. First, the minimum number of cases evaluated for reliability for each measure decreased from 125 to just 20. In 2017, MIPS eligible clinicians or groups that do not meet the required case minimum for any resource use measures would not be scored on this category. The VM program adjusted for inpatient DRG and other factors, with a separate adjustment applied for specialty composition of group practice, whereas the proposed cost category removed the specialty adjustment and modified the way individual cases are aggregated for a single score. We had mentioned the new clinical episodes that would now be offered. And then the last difference to note is replacing VM TIN attribution with performance evaluation at the individual TIN/NPI and group TIN levels. So for reporting purposes, ECs can submit data under MIPS as an individual or a group. If an EC is assessed in all other MIPS categories as an individual EC, they are monitored by NPI/TIN rather than just TIN, and are measured based on cases specific to their practice rather than all cases attributed to the group TIN. If an EC is participating in group reporting, they will be monitored using the group TIN under which they report. Now for the cost category takeaways. Resource use or cost is 10% of the MIPS score in year 1, and this will actually do the opposite. This will slowly increase to 15% in year 2 and 30% from year 3 and beyond. The category score will be calculated based on Part B claims, which means there's no reporting or attestation required, and all resource use measures are weighed equally, and there's no minimum number of measures required. The third category is completely new and is called Clinical Practice Improvement Activities, or CPIA. There's a minimum selection of 1 CPIA activity from 90+ proposed activities, with additional credit for more activities, full credit for patient-centered medical homes, and a minimum of half credit for APM participation. And key changes from the current program, well, it is brand new, so that doesn't really apply, but its year 1 weight will be 15%. So there are 9 subcategories of activities, in which 6 are actually specified in MACRA, and they're expanded practice access, so think same-day appointments for urgent needs or after-hours access, population management, such as monitoring certain health conditions of individuals, care coordination, such as timely communication of test results, or the use of remote monitoring or telehealth, beneficiary engagement, such as the establishment of care plans for individuals with complex care needs, patient safety and practice assessment, such as the use of clinical or surgical checklists, and participation in an APM. And then 3 additional subcategories, which are achieving health equity, integrated behavioral and mental health, and emergency preparedness and response. So within these subcategories, there are over 90 activities to choose from. CPIA reporting. In year 1, all MIPS eligible clinicians or groups must designate a yes/no response for activities on a CPIA inventory. For third-party submission, MIPS ECs or groups will tell their health IT vendor which CPIAs have been performed, and they will submit on their behalf. So some key CPIA category takeaways. are that CPIA is 15% of the MIPS score in year 1, certified PCMH gives full credit, and participating in an APM gives half credit. There are over 90 activities to choose from found in Table H of the proposed rule. MIPS ECs need to reach 60 points, so some activities count for 10 points, and there are a few that count for 20. CPIA activities must take place over at least a 90-day period during the performance year. Partial credit will be awarded if your total points is less than 60. And fewer activities are required for small groups consisting of 15 or fewer clinicians, rural, HPSA, and non-patient-facing providers. So there are some special considerations these MIPS eligible clinicians or groups receive. They actually receive partial or full credit for submitting 2 activities of any type of weighting. So for example, 2 medium activities, which are 10 points each, will qualify for full credit for these types of providers. I also wanted to point out why I highlighted certified. So to receive full credit, an EC must participate in a certified PCMH. And those recognized certifying bodies are the AAHC, the NCQA, the Joint Commission, and URAC. Now, on to our last, most complicated category, advancing care information. So scoring is based on key measures of patient engagement and information exchange. There's flexible scoring for all measures to promote care coordination for better patient outcomes. And key changes from the current program, which is the Meaningful Use program, is that it dropped the all or nothing threshold for measurement. It removed redundant measures to alleviate reporting burden. So it eliminated clinical provider order entry and clinical decision support objectives. And it reduced the number of required public health registries to which clinicians must report. And in year 1, its weight is 25%. What to know about this category is that it's a Meaningful Use program. It's just revamped, but the core structure still remains, and it really isn't going anywhere. So the overall ACI score is made up of a base of 50 points and a performance score of 80 points for a maximum of 100 points. And yes, math people out there adding this up in your head right now, you can earn over 100 points because you have this flexibility to pick measures that will benefit your patient population. Now, this is the most complex scoring category, so if this is the first time you're seeing it or hearing about it, don't feel bad if you aren't picking it up right away. It took me multiple times to understand how this category even works. So you start off with a base score of 50 out of 100 total points. For this base score, you must report numerator, denominator data, or a yes-no attestation. But as long as functionality is on, you should be good to go and be all set. There are no thresholds. However, a huge part of this is the security risk analysis, which must be performed in order to receive any credit. If it's not, you will automatically receive a 0. Then you add your performance score, which you can get up to 80 points in, depending on performance and the measures you choose to report on. And then you can get a bonus point. So the overall ACI score is base plus performance plus bonus point. And it must total 100 points in order to earn the full 25 points for the ACI category. So scores of less than 100 will reduce points proportionately for that category. So if we take a look at the base score first, the base score is 50 percentage points of the total advancing care information category. To receive the base score, ECs must provide the numerator or denominator or yes-no for each objective and measure. ECs would be required to report on 6 objectives and their measures for the base score. And the objectives are, number 1, protect patient health information, which requires a yes attestation. Electronic prescribing, which requires numerator-denominator data, as does patient electronic access, coordination of care through patient engagement, and health information exchange. And then lastly, immunization registry reporting, which requires a yes attestation as well. So this last objective, which we used to call public health reporting, now requires only immunization registry reporting to earn the base score points. Completing any additional measures under this objective would earn 1 additional point toward the total ACI performance category score. So this is where that bonus point comes in. So options include the following that are worth 1 bonus point: syndromic surveillance reporting, electronic case reporting, public health registry reporting, and clinical data registry reporting. To make things even more confusing for us, there are multiple base score models offered in the proposed rule. Base score models are based on what version of certified EHR technology an EC is using. So there's a primary proposal, and then there's the modified primary and alternate proposals. And these are intended for eligible clinicians still using 2014 edition cert in 2017. This proposal follows the modified stage 2 objectives and measures without thresholds and is an option for 2017 only. So if we look at the difference between the primary and alternative base score proposals, the primary method has CPOE and clinical decision support eliminated, whereas the alternative proposal would include a yes-no for CDS and numerator-denominator data for CPOE. So as of now, most NextGen clients are on the 2014 edition, and NextGen has not released a date they will be 2015 certified, which means eligible clinicians would be required to report on the alternate proposal, which correlates to the modified stage 2 objectives and measures that everyone's reporting on this year. Now moving on to the performance score. The performance score accounts for 80 percentage points towards the total advancing care information category score. And ECs select the measures that best fit their practice from the following objectives: patient electronic access, and that has 2 measures, and that's patient access and patient-specific education. Coordination of care through patient engagement, and that has 3 measures as well. That's the view, download, transmit, secure messaging, and then a new patient-generated health data. And then we have health information exchange, and that has 3 measures as well. And that's exchange information with other physicians, exchange information with patients, and clinical information reconciliation. So we have 3 objectives with 8 measures, and each measure is assigned 10 points, with 80 points possible. So let's look at meaningful use versus ACI. Past requirements for the Medicare EHR incentive program were that it was one size fits all. Every objective reported was weighed equally. The new proposal for advancing care information category is it's customizable. Clinicians can choose which categories to emphasize in their scoring. MU required across-the-board levels of achievement or thresholds, regardless of practice or experience. Whereas ACI is flexible, it allows for diverse reporting that matches clinicians' practice and experience. MU measurement emphasizes process, whereas ACI measurement emphasizes patient engagement and interoperability. Meaningful use was disjointed and redundant with other Medicare reporting programs, whereas ACI is aligned with other Medicare reporting programs, and there's no need to report redundant quality measures. And meaningful use had no exemptions for reporting, whereas ACI has exemptions for reporting clinicians in advanced alternative payment models in their first year with Medicare, or if they have low Medicare volumes. And then some other important things to note are that the ACI category is optional for 2017 for NPs, PAs, clinical nurse specialists, and CRNAs because they've never done it before. We mentioned that CPOE and clinical decision support measures were deemed topped out and removed. Also, the meaningful use requirement for reporting CQMs has been pulled since it's already covered in the earlier quality performance category. And finally, that a security risk analysis must occur. Otherwise, 0 points will be rewarded in this category. If we look at hardships and exclusions, both of which we've been accustomed to, number 1, there will be no more exclusions. And the main reason being for the 3 populations of clinicians already exempt from MIPS, as well as the elimination of thresholds. But there will be a hardship exemption offered to MIPS ECs facing a significant hardship. So if 2017 was the first year they would have attested to meaningful use, they can file a hardship exemption for only the ACI portion. If the proposed rule is finalized without change, that is. But the hardship would equal a reweighting of the category to 0. So if we take a step back from the 4 categories and look at the overall MIPS timeline, 2017 will be the first performance period, and performance feedback will be available at least annually starting July 1st, 2017. At a minimum, this feedback will address quality and cost performance categories. In 2018, we will see ECs reporting and submitting data in the first few months, with the second feedback report coming out and a targeted review based on 2017 MIPS performance. And in 2019, we will see the first payment adjustments take effect from the 2017 performance period. Now, I did mention this earlier, but I wanted to reiterate that eligible clinicians can participate in MIPS as an individual or as a group. A group as identified or as defined by a taxpayer identification number, or TIN, would be assessed as a group practice across all 4 MIPS performance categories. Now, a special clarification made by CMS addressed if a PA, NP, or other eligible clinician bills under another EC's NPI, then that PA, NP, etc. would not be subject to MIPS. Now that we know ECs can report as either an individual or a group, we can look at each type of data submission option available by category and reporting type. I won't read through all of these, but I wanted to include this because I think it's a great resource when we send this out. All right, now that we've gone through an overview of MIPS and each of the 4 categories and their requirements, let's look at MIPS scoring and payment adjustment. Let's start with a scoring breakdown. A single MIPS composite performance score will factor in performance in the 4 weighted performance categories on a 0 to 100 point scale. The MIPS composite performance score, or CPS, will be compared to the MIPS performance threshold to determine the adjustment percentage the EC will receive. So if we look at each category of MIPS scoring, we have quality, where clinicians choose 6 measures to report to CMS that best reflect their practice. One of these measures must be an outcome measure or a high-value measure, and one must be a cross-cutting measure. Clinicians can also choose to report a specialty measure set. Each measure is worth 1 to 10 points. An EC will receive 0 points for a measure that is not reported. And measures are averaged to get a score for the category. And the maximum possible points for this category is 80 to 90, depending on the group size. And the percentage of overall MIPS score is 50%. Advancing care information, clinicians will report key measures of patient engagement and information exchange. Clinicians are rewarded for their performance on measures that matter most to them. So there's a base score of 50 points and then a performance score of 80 points with the possibility of a bonus point for public health reporting and a total cap of 100 points available. And the percentage of overall MIPS score is 25% in year 1. Clinical practice improvement activities. Clinicians can choose the activities best suited for their practice. The rule proposes over 90 activities from which to choose. Clinicians participating in medical homes earn full credit in this category, and those participating in advanced APMs will earn at least half credit. Each activity is worth 10 points, with double weight for high-value activities. And ECs should take their total of activity points and compare it to the target of 60 points. And the percentage of overall MIPS score is 15%. And then cost. CMS will calculate these measures based on claims and availability of sufficient volume. Clinicians do not need to report anything. And to get the score, they average the score of all cost measures that can be attributed. And the percentage of overall MIPS score is 10%. So now looking at the scoring system as a whole, the main theme we keep seeing here is converting measures and activities done by the provider to points, and then comparing those points earned to a threshold, which the ECs will know in advance. Also, partial credit is available, so performance at any level will improve your CPS, which is important because, yes, MIPS scores will affect payment, but it will also affect reputation because these scores will be made public. They can be published to the Physician Compare website, which is a 5-star rating system for providers. Now I included the breakdown of scoring for each individual category to show you how CPS is formulated. However, for the sake of time, I'm not going to read through each of these, but I did want to include them for your reference when we send the slides out. So we have quality scoring, cost scoring, CPIA scoring, and a review of ACI since we already went over that category. So back to an overview of the entire MIPS program scoring. I really like this graphic CMS supplied with the 6 steps to determining a clinician's payment adjustment. So first is data submission by an EC, either as an individual or as a group. Next is category scoring, so going through each of those 4 categories, evaluating performance, and converting those measures and activities into points. Which brings us to step 3, calculating the composite performance score based on category weights. Now between steps 3 and 4, CMS must determine which TIN or NPIs are still in MIPS after exclusions. They have to assign the TIN/NPI the proper CPS score, and calculate an NPI CPS score that can be used if an NPI bills under a new TIN number. Then you would compare the CPS with the CPS performance threshold established. Next is payment adjustment determination and scaling. And then finally, payment adjustment application. Now that we know how payment adjustments are applied, let's look at the actual adjustment percentages. So NextGen did a really great job of creating this chart showing the payment adjustments throughout both sets of programs, the current independent programs and then the streamlined MIPS program, so providers know what to expect. First thing we want to remember is that payment is based on performance year 2 years prior. So you can see performance year 2016 will affect payment in 2018. And this year it has up to a negative 10% adjustment if an EP does not report meaningful use, PQRS, or VM. If we look at performance year 2017, or next year, which is the first year MIPS goes into effect, we can see the maximum negative adjustment increases every year, starting at negative 4% and capping out at negative 9%, whereas the positive adjustments increase at a much faster rate. So if we look at an adjustment breakdown, we know a MIPS EC's payment adjustment percentage is based on the relationship between their CPS, or composite performance score, and the MIPS performance threshold. So a CPS below the performance threshold will yield a negative payment adjustment, and the CPS above the performance threshold will yield a neutral or a positive payment adjustment. A CPS less than or equal to 25% of the threshold will yield a maximum negative adjustment of negative 4%. A CPS that falls at or above the threshold will yield a payment adjustment of 0 to plus 12%, based on the degree to which the CPS exceeds the threshold and overall CPS distribution. An additional bonus will be applied to payments to ECs with exceptional performances. So really all that matters is what your CPS is in relation to the MIPS threshold. A payment adjustment change that I know will affect many of our clients is that payment adjustment exclusion for the specialty codes listed below has been removed, meaning all of these you see on your screen right now are now included. And some important points to keep in mind in regards to MIPS scoring and payment adjustments are that all eligible clinicians above the performance threshold will be eligible to receive positive payment adjustment. Even though the program is budget neutral, there's no requirement that a certain number of ECs must receive a negative adjustment, and benchmarks will be known in advance. However, to get incentives, you must submit data. If not, you will get 0 performance and a negative adjustment. All right, that wraps up our review of MIPS. We will now move on to a very brief overview of APMs, and I will go ahead and turn it over to Cindy Kincaid for this. Cindy, whenever you're ready.
Oh my goodness, I almost fell asleep there. So I hope everyone out there is awake and still hanging with us, because as I said, this is very dry material, and we looked at a lot of ways to try and make this more entertaining, and frankly with the subject matter and what we're talking about, there's just nothing entertaining about it, so we're just going to get right to it. As we talk about alternative payment models, we could just skip this section entirely, since the projection that we talked about earlier in the PowerPoint indicates that providers will largely be excluded from the MIPS the first year, and even as we are presenting this webinar, CMS is busy drafting changes to these models based on feedback they've received. However, we do think a few points are worth mentioning, so we're going to move through it very, very quickly. First of all, if you look at the advanced payment models, eligible entities that participate in APMs must require the use of a certified EHR technology. You have to have an EHR that is absolutely certified to be able to report and monitor these type of programs. You must provide for payment for covered professional services based on quality measures comparable to measures under MIPS performance category, and you must be prepared to bear financial risk for monetary losses under the APM that are in excess of a normal amount or are medical homes expanded under the Center for Medicare and Medicaid Innovation. The list of models included in the proposal rule as advanced APMs are the Comprehensive ESRD Care Model, the Comprehensive Primary Care Plus, the Medicare Shared Savings Programs Track 2 and Track 3, the Next Generation ACO Model, Oncology Care Model 2 Cited Risk Arrangement, and that will not be available until 2018. And then finally, other payer APMs will be available in 2019, such as commercial payer ACOs. Under MACRA, qualifying APM participants are eligible for incentive payments. In the years 2019 to 2024, providers qualifying for the APM track will receive a 5% annual lump sum bonus on MPFS payments. Providers must meet increasing thresholds for the percentage of their revenue they receive through eligible APMs. So, for example, in 2019 and 2020, 25% of Medicare revenue must be received through eligible APMs. Qualifying providers are excluded from MIPS. If we take a look at this chart showing the APM scoring standards, I won't go through each of these items, but what you want to consider that is to be considered part of the APM entity for the APM scoring standard, an eligible clinician must be on an APM participation list on December 31st of the MIPS performance year. I think we covered all of these other items, but it's really important to keep this date in mind because if you are going to be participating, you must be on that list by December 31st of the year that you intend to participate. And finally, we have a nice MACRA timeline, and this I think sums it up very well. If you take a look at the years and how this is going to be deployed, we'll start with the fee schedule updates. As you can see, if you're working on a fee schedule based or traditional payment method, your fee schedules are going to go up 0.5% each of the years in 2016, 17, 18, and 19. If you're looking at MIPS, you'll base everything on the quality resource use, clinical practice improvements, and meaningful use of certified EHR technology. And what you will see there is that starting in year 2019, you will see an either 4% increase or decrease in your payment adjustments. So it could be 4%, then 5%, and 7%. And finally, if you're a qualifying APM participant, there's an opportunity for a 5% incentive payment, and you are excluded from MIPS. And that's where they think, at least in the first year, that's pretty much where everyone's going to be, or the vast majority. The key takeaways from this section is the Quality Payment Program changes the way Medicare pays clinicians and offers financial incentives for providing a high-value care. Medicare Part B clinicians will participate in the MIPS unless they are in their first year of Part B participation, become QPs through participation in advanced APM, or have a low volume of patients. Patient adjustments and bonuses will begin in 2019. The final rule is expected by November 1st, 2016, and MACRA makes no changes to 2016 meaningful use. And that's a very important point that, as Lindsay mentioned earlier, even though we're hoping and we believe that 2016 is going to be reduced to a 90-day attestation period, right now everyone should still be planning for meaningful use participation for the full year in 2016. So how does this affect me? I think this is another really great graphic from CMS. And I won't go through each of these items, but please take a look at this when you get the slide deck, because it tells you if you're in an advanced APM and yes or no, and it follows it through the process and then takes you to the bottom line where there will be financial incentives for participating in an APM even if you don't become a QP. So as we prepare for success, I'm going to turn this over to Kathy Thompson. Kathy is one of our leading specialists in meaningful use, and she will take you through some of the pros and cons of this program and how you can be prepared as you move forward. So Kathy, turning it over to you.
Okay, preparing for success. So these next couple of slides, what I want you to do is, as I'm asking these questions, think about how prepared you are and where you stand today. Preparation questions for quality. Did you successfully report PQRS? Physician quality reporting. Did you focus on your CQMs and did you align them with your PQRS measures? How are you reporting? Are you reporting your CQMs with your PQRS measures? Are you reporting your CQMs with your meaningful use attestation? What measures are you reporting on? Do they match any offered under the MIPS quality category? Preparation questions for resource use. How did you do on value modifier? Do you know what value modifier is? Are you seeing any payment adjustments today? Do you know if you're seeing a payment adjustment? Do you know how to review your QRURs, which are the quality and resource use reports, which are extremely important to the future of Medicare payments? Enterprise Identity and Management Systems, EIDM, account required to access the QRURs are available at portal.cms.gov website. Preparation questions for ACI, Advancing Care Information. Did you successfully report meaningful use in 2015 or previous years? Did you take advantage of the hardship in 2015 rather than a test? Are you prepared for a full year of attestation in 2016? Have you recently ran your HCOM reports? Are there any measures you are close to not passing, such as patient portal? After running HCOM reports, would you pass MIPS ACI category today? Preparation questions for CPIA, Clinical Practice Improvement Activities. Have you looked at Table H in the proposed rule? Are you currently participating in any activities listed right now? Are you a PCMH? Are you thinking about being a PCMH? Why do I ask? Many of the incentive programs have similar measures and criteria, and as you can see, they're aligning. If you are meeting one incentive program today, you may be on your way to meeting another. By failing to prepare, you are preparing to fail.
Okay, Kathy, and that's really just a few questions that we wanted to throw out and that we can certainly help you with as you move forward. If you talk about MACRA or if you've attended any of our previous webinars on HIPAA or on meaningful use audits, let's talk about next steps if you feel that you maybe need some additional help or you just want to have copies of the slides or visit some of our past webinars. First of all, you can visit us at itentive.com. You can sign up for our informative webinars and blogs. And then as part of the assessment and as part of MACRA, one of the things that's very important is the security risk analysis, and we've really been hitting on that the past 3 webinars. First of all, we can help you with your self-assessment. We can conduct a remote security risk analysis, and we can even take it as far as an on-site security risk analysis depending on how far you would like to go. This is a really important area that we are focusing a lot of our efforts on right now, so I do want to talk a little bit about the security risk analysis. We can help you perform a thorough and accurate HIPAA risk analysis. As part of that, we can manage your HIPAA security risk analysis and guide you step by step through the entire process. Our methodology leverages the proven and tested HIPAA One software platform, which includes a comprehensive set of compliance questions that will act as a repository for maintaining the interview responses, supporting documentation, or remediation action plans. Remember, as part of HIPAA and as part of your security risk analysis and moving forward into MACRA, it is not just about your EHR system. It is about your entire security system throughout your practice, throughout your environment altogether. No one is excluded from this. So as part of that, and if you were to sign up for our program, we will review your interview response questions with your team and your employees and your providers and provide supporting materials and identify areas which need additional information or clarification. We can identify threats, vulnerabilities, and analyze controls in place. We can guide the development of your remediation plan by prioritizing risks through their likelihood and impact. Let's put them in order as to how likely they are to be impactful to you so that you can move forward, because one of the most important things is even if you aren't fully ready, you have a remediation plan. We can help you track and document your ongoing remediation efforts throughout the year, and then as a part of this, we will be an ongoing resource to answer your HIPAA and meaningful use compliance related questions. So now let's turn it over to questions about this. As I said, this has been a really dry presentation. There's a lot of information we've thrown at you. And honestly, we're all still learning, and MACRA is changing day to day. So we'll do our very best to answer your questions, and we'll take it from here.
Okay, thank you, ladies. Really appreciate it. Again, questions may be entered in the questions area of the webinar control panel. And we will be emailing out links to a copy of the recording as well as the slides later this week. So keep your eyes out for that. Okay, first question. Would you give an example of the type of data that is collected automatically and which ECs don't have to report? And that goes back to slide 26, Lindsay.
Oh, sorry. I think I was muted.
You were.
Yeah, I can go ahead and, yeah.
Don't lie, you were asleep.
No, we picked it up at the end. And I'm going to actually refer you back when we send out these slides. I included a slide in there, and it's MIPS data submission all categories. And it actually goes through all 4 category types by individual reporting or by group reporting. And what you're referring to is that claims-based reporting. So it's when CMS is actually taking the data from your administrative claims for Medicare patients only and using that data. And they're really trying to get this in place for 3 out of the 4 categories. Obviously, advancing care information, we will probably never have this in place. But as of right now, for CPIA, they are looking at putting this in. They haven't decided if it's technically feasible yet. But so for right now, CPIA is reportable. But for quality and for resource use data, that should be able to actually taken out automatically. For example, how they would put this into place. If you did telehealth, when you're billing for telehealth, you're going to put that modifier on there on your claim. They should automatically be able to read that and then give you credit for that activity. So that's how that automatic claims process would work. But I would definitely have you go back to that MIPS data submission category if you wanted to see specifically individual versus group and by category type, which process for reporting is automatic. Kathy, I don't know if you have anything to add to that. You're kind of our reporting guru.
Sorry, I was on mute. Well, if you think about it, what this, as I'm listening to Lindsay talk, this is comparable to if you ever did claims-based reporting for PQRS. It's going to pick up that information automatically. That would be the only thing I would add that comparison to kind of give you an idea of how this will work.
Okay, great. Thank you both. Next question. What if a clinician changed groups after the performance period?
I can grab
Lindsay,
that one
do you maybe
too
want
as
to
well.
take it? Okay, thanks.
Yeah, no problem. So interesting about this, CMS has actually clarified this. They have stated performance in these categories and performance, so your composite performance score follows NPI. So if the clinicians worked for 110 on the performance period, and then that EC's adjustment will stay with it. It'll stay with you by NPI, and it'll be based on that old 10, so it'll follow you through each year.
Okay, thank you, Lindsay. And it looks like we only have one more question at the moment. So, but you know, if anybody's still typing right now, we're going to hang on and answer questions as long as you keep asking them. So, last question: what happens if a clinician does not meet a measure requirement?
I can take that one. Then they get 0 points for that measure, and it will not count towards their score.
Yeah,
okay, cut and dry, huh?
Yeah, if you're not meeting a measure requirements or you're not reporting data, you're going to get 0 points, and it just won't count towards your end score. So we don't have this pass-fail methodology anymore. It's nice. We have this partial credit that's being given. So anything you can report or anything you can give them is only going to add to your performance score and get you closer to that threshold.
And again, remember it's a threshold, so you can go over 100. So when you're thinking about this, if you get a 0 on one, which you hopefully wouldn't do because if you picked it and your goal is to achieve it, but if you fail to meet it and you meet all of the others that you've done and you still achieve the threshold, you're still going to be fine.
Okay, great. Thank you for that clarification, and thank you everybody who joined us today. I hope that this was informative. I know there was a lot of information out there, so do keep your eyes out for an email with a link to the recordings as well as a PDF of the slides. Sometimes that ends up in our spam boxes for some reason, so if you don't see it, check there, or feel free to reach out to any of the people that you see up on the screen, and we would all be happy to send them to you as well. So thanks for joining us today, and I hope that you have a great week. Ladies, thank you all for your hard work with this presentation.
Thank you.
Yes, thank you.
Bye.